the nice thing about the guidelines with these reporting method is that they gave us specific things to recommend when we're doing the report. So for stable chest pain patients, which is this first algorithm, from 3, 4, and 5, there is specific things depending on the amount of plaque that you can consider. So functional assessment starts to become important in CAD RADS 3. And then when 4 and 5 is denominated, invasive coronary angiography it's going to be mostly recommended. And then I did not include here 0 because that's normal. So consider something else for the chest pain. And then for acute chest pain, similarly, I'm not going to go over everything, but the important thing to know is that they give, specifically, I think our emergency medicine colleagues, some guidelines on what to do with the patient. So 3 and above, we're going to consider hospital admission, consider a stress test, and then for 4 and 5, similarly, consider invasive ischemic evaluation. And so what exactly are we talking when we talk about plaque, right? So that's the second modifier. So this is accumulation of lipid or inflammatory cells, fibrous tissue, and sometimes calcium. And the 4 important things to know about that is that we can qualitatively analyze the plaque. We can and again, that's going to be institution and reader dependent to a degree. Quantitative plaque now with software algorithms and AI will help us distinguish minimal plaque and also plaque composition. And again, we're reporting that because we know from large cohorts followed by years that plaque burden is significant when we talk about events. And then again, I talked about why is it important to identify high-risk plaque. So anything more than 1 millimeter within the coronary arterial wall, similar to cardiac MRI with LGE, you have to identify it in at least 2 planes to actually call it. And then you have to distinguish that from epicardial fat. So those are the 3 basic things that you need to know. Most readers continue to use the percent diameter stenosis for visual estimation. So it's going to be 1 minus your minimum diameter divided by maximum diameter of reference. And then most people now use the mean diameter. So this is kind of true also for carotid stenosis. And basically, this has just been widely accepted. People use it all the time. And important to know is that when performing quantitative assessment with software, then there is subvisual measures of plaque, so pretty much naked to the human eye. Just scrolling through these really quickly in interest of time, the softwares are gonna be analyzing the plaque by volume, by diameter, in different sectional views. And basically I'm gonna mention the variables here, so just so that you know that this is reported in the expert consensus document of 2024 from the SECVCT. So lumen, basically what's inside. Vessel is the space within the outer vessel boundary on both sides. We talked about what plaque is, and then we need to know the length. These are all going to be reported in both diameter and area. And then with softwares and calculations, you can also derive the volumes. So these are here on the slides for you to review on your own time. And just for these quantitative methods, there's the new SACC scientific statement on this, says to use this with, I guess, caution. Obviously, between institutions, between vendors, there's going to be a little bit of variability. There's lots of advantages. So maybe more objective, more reproducible. It correlates well with invasive angiography measures of plaque, but lots of limitations too, such as maybe limited prognostic and outcomes data. So if we're quantifying things that we cannot see with our own eyes, we still don't have the data to say, to know what to do with those patients. And everything that you bring in is going to come out. So the quality matters at every step. And so when you're reporting, you're basically including your quality at every step of the time. And so with that, we are going to go and work on 2 other cases. Okay, so I'll go ahead and tell you what I'm seeing here on my LAD reconstruction here. So there's some calcified plaque here where I'm looking, and you can see there's that lumpy, bumpy outer lumen to the vessel throughout the mid, all throughout the mid here. So now we're going to be interested in this area here. So this is CAD RADS 2.0